Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, hello everyone. Today we're going to dive deep into the drug therapy of bronchial asthma. We'll be looking at the key medications that help millions of people manage their symptoms and, just breathe a little easier every single day. So let's start with the basics. What exactly is bronchial asthma? Well, at its core, it's a chronic inflammatory disorder. And that word chronic is key. This isn't something that just comes and goes. The main features you need to know are airway obstruction, that's reversible, meaning it can open back up, and something called bronchial hyperreactivity. That's just a fancy way of saying the airways are extra sensitive and they overreact to triggers, leading to that sudden tightening we call a bronchospasm. Okay, take a look at this. This flowchart is basically our roadmap for this whole discussion. It lays out the entire process beautifully. It all kicks off with a trigger, maybe an allergen, which sets off this whole cascade of events. And you'll notice it splits into two distinct paths. There's the early response, which is that immediate bronchospasm, and then there's the late response, which is all about inflammation. Any effective treatment has got to tackle both of these. So here's our game plan. First, we'll get a handle on the two main problems in the asthma battlefield. Then we'll look at the drugs that give you that immediate relief, the bronchodilators. After that, we'll get into the real cornerstone of long-term management, corticosteroids. We'll also touch on some other key modifiers, and then wrap up with the really cutting-edge stuff, biologic agents. All right, let's set the scene. The fight against asthma is really happening on two main fronts. You've got the immediate muscular squeezing of the airways, that's bronchospasm, and then you have the slower, more nagging problem of inflammation. So that early response, that's the acute attack. It's the bronchospasm, an immediate tightening of the muscles around your airways. That's what causes the wheezing and the sudden shortness of breath. But the late response, that's the inflammation. It's a much slower burn involving swelling and extra mucus. And this is what makes the airways chronically sensitive in the first place. The bottom line is, you can't just treat one and ignore the other.
Okay, so let's talk about the first line of defense when an attack hits, the bronchodilators. And the name really says it all. Their main job is to open up or dilate the bronchi.
Now, the most important ones here are the beta-2 agonists. So how do they work? Well, they stimulate specific receptors in the lungs called beta-2 receptors. This kicks off a chemical reaction that relaxes the smooth muscles in the airways. We split them into two main camps. You've got your short-acting beta agonists, or SABAs, like salbutamol. Think of these as your rescue inhalers for quick relief. Then you have the long-acting ones, or LAVAs, like salmeterol. These are for prevention, or prophylaxis, to keep the airways open over a longer period. But while beta agonists are definitely the stars of the show, they're not the only actors on stage. You've also got methylxanthines, like theophylline. They work to relax the airways, but they do it by stopping an enzyme that would normally break down the relaxing signal. And then there's a totally different approach with muscarinic antagonists, like ipratropium. These guys work by blocking the nerve signals that tell the airways to tighten up in the first place. So you see, three different paths to get to the same destination, open airways. Let's just zoom in on theophylline for a second. It's a classic, it's powerful, but it comes with a catch. It has what we call a narrow safety margin. And what that means is the dose that helps is really close to the dose that can cause toxic side effects. Plus, everyone processes it differently. Smokers clear it faster, while someone with liver disease will clear it much slower. And it interacts with a ton of other drugs. So the crucial point here is that it absolutely requires careful monitoring. Okay, so we've covered the relievers. Now let's pivot to the controllers. Because while bronchodilators are great for putting out fires, you really need something to manage the underlying disease. And that means tackling the inflammation. The absolute cornerstone of that approach is a class of drugs called glucocorticoids. These drugs are incredibly effective because they launch a multi-pronged attack on inflammation. They shut down the production of all sorts of inflammatory signals, like cytokines and leukotrienes. They also stabilize the membranes of cells, like mast cells, basically locking the door so they can't release their inflammatory chemicals. And here's a really neat bit of teamwork. They actually make the beta-2 receptors more sensitive again, which makes those reliever inhalers we just talked about work even better. Now, how these drugs are given depends entirely on the situation. For your day-to-day preventative treatment, an inhaled steroid like beclomethasone is the first choice. It goes right where it needs to. For a really bad flare-up, a doctor might prescribe a short course of oral prednisolone. But in a true life-threatening emergency, something called status asthmaticus, hydrocortisone is given directly into a vein for the absolute fastest effect possible. Of course, with powerful drugs come potential side effects. With inhaled steroids, the issues are mostly local, things like a hoarse voice or a yeast infection in the mouth called thrush, which, by the way, you can often prevent just by rinsing your mouth out after you use the inhaler. But when you get into long-term systemic use, that's the oral or IV stuff, the risks are a lot more serious. We're talking about things like osteoporosis, messing with your body's own steroid production, and a higher risk of infection. So beyond those two big classes of drugs, we have others that are a bit more specialized. They modify the inflammatory process by targeting very specific pathways. Let's see how they fit into the picture. So, we mentioned leukotrienes are one of the key troublemakers in asthma inflammation. Well, we have drugs that go after them specifically. You've got montelukast and zafirlukast, which work by physically blocking the receptors that leukotrienes need to bind to. Then there's xyleutin, which goes a step earlier in the process and blocks the very enzyme needed to create leukotrienes in the first place. These are great as add-on therapies, and they're especially helpful for people whose asthma is triggered by things like aspirin or exercise. Here's a totally different strategy. Meet the mast cell stabilizers, like sodium chromoglycate. Now, these don't open the airways at all. Instead, their job is to prevent the mast cells from ever releasing histamine and all those other inflammatory chemicals. They stop the allergic reaction before it can even get started. They're purely for prevention and are used quite a bit in children. And that brings us to the newest and most targeted treatments we have, biologic agents. This is really where asthma therapy becomes a form of precision medicine. So it begs the question, what do you do for patients with severe asthma that just doesn't get better with high-dose steroids and bronchodilators? Well, the answer lies in going after the very specific immune molecules that are driving their particular type of asthma. And this table shows you just how precise we're talking about. For someone with severe allergic asthma, we can use a drug called omalizumab. It's an antibody that literally finds and neutralizes immunoglobulin E, or IgE, which is the main antibody in allergic reactions. On the other hand, for someone with severe eosinophilic asthma, that's a type driven by an immune cell called an eosinophil, we can use a drug like mepolizumab. It targets a signal called interleukin-5, which is the main thing telling those eosinophils to stick around and cause trouble. So if there's one single thing to take away from all of this, it's this. Truly effective asthma therapy isn't about one magic bullet. It's a strategic, two-pronged attack. You have to target the immediate symptoms of bronchospasm with your relievers, and you have to control the underlying chronic inflammation with your controllers. And this really leads us to a final thought, doesn't it? The rise of these biologic agents shows a clear path toward ever more personalized medicine. As our understanding of immunology and the different flavors of asthma gets deeper, you have to wonder, just how much more precise and tailored can these therapies get in the future? It's a pretty exciting question to think about. Thanks so much for joining me.